This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1188, recorded on January 25, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
What's on your tie, Daniel?
It's my antibody bow tie, so I can demonstrate that I actually am pro-vaccine.
Who would say otherwise?
Well, there are some other people who are not actually pro-vaccine. So maybe we know who we're talking about.
Don't get it.
Maybe we'll even get into that, but I try to avoid being political. I think it's been a rough last couple days. I'd say last week or more for a lot of us. I have my TWiV. It's my TWiV mug, full of coffee, just in case I need, partway through, because we have a lot to talk about. It's amazing. So first, let's start off with our quotations. I'm going to start off with Marcus Aurelius, and then we're going to get a quotation from Daniel Patrick Moynihan. So first, everything we hear is an opinion, not a fact. Everything we see is a perspective, not the truth. And then from Daniel Patrick Moynihan, you're entitled to your opinion, but you are not entitled to your own facts.
Here's one for this week that was sent to us. It's a Turkish proverb. When a clown enters the palace, he does not become king. The palace becomes the circus.
All right, see, I am so much better at not being political than you seem to be.
Well, you're more important. Yeah, I'm just the scientist here. I can say what I want. But I just resent the co-option of science by politics in the way that it's been co-opted lately. Last 20 years.
Yeah, no, I mean, it was what we sort of said, like tongue in cheek, you mix politics and science and you get politics. But yeah, unfortunately, it's become, science is no longer respected as a process, a way of finding out what's true. It's being manipulated for votes and other things. It's really.
Yeah, this guy, Vinay Prasad?
Mm-hmm. Yes.
An oncologist. It's ridiculous. So he believes in the lab leak theory, and he said all those discussions on TWiV, they're all so boring.
Oh my God!
Yeah, maybe because you don't understand them.
Which is a shame, because he was supposed to have undergone some degree of education. So to find actual evidence and science. What is it they say? Some news outlets have listeners, watchers. Some news outlets have fans.
Yeah, right.
All right. Well, we've got a lot to cover today. Actually, so much that I'm going to start with almost a bullet point list before I get into what I think is the most critical for us to talk about. So, first, for the first time in more than 60 years, the CDC's Morbidity and Mortality Weekly Report was not published as scheduled. That was last Thursday. That's this Thursday. So, Second, another confirmed case of Marburg in Tanzania. The WHO is ramping up the response. I just had WO, but it's WHO. It's the US that is leaving, not the H. All right, the next is norovirus. Just people are asking, Moderna is working on an mRNA vaccine to cover 70 to 80% of the circulating genotypes. And they've got one in a phase 3 trial, and we are still seeing lots of norovirus. TB, I was going to put this in, but so many people asked about it. Major tuberculosis outbreak hits Kansas City area. And an outbreak of tuberculosis in Kansas City has grown into one of the largest ever recorded in the United States, with dozens of active cases. And they have 3 bullet points, which I thought was interesting. So the summary, they give us a summary right up front in this Reuters article. 67 active TB cases reported in Kansas City. 384 people managed for TB testing and treatment. And they say CDC assists with contact tracing and health education. I don't know what impact we've seen in the last 8 or 9 days with what's happening there.
Why do we have this big outbreak? Do we know?
There wasn't as much information as I would have liked, so I'm not exactly sure. I was trying to figure, was this a nursing home? Was this in some kind of a context? Because that is where we often see this. So I'm not sure I'm getting enough information, and that might be sort of what happens in coming weeks. I'd love to see a nice CDC MMWR report or or a health alert network alert letting me know what's going on, what we as clinicians on the ground need to be worried about.
Right now, there's no communications allowed, so you're not going to get it, Daniel.
Yeah, not for the moment. People are still, okay, I'm just going to stop there because, of course, nobody is communicating with me because they'd be breaking the rules if they let me know what was going on.
Well, apparently a CDC person who communicated with WHO has been fired.
Yeah.
So, I mean, the communications halt is disturbing because it means they want to control the information, and that's not the way it works. You got to publish everything. You can't say we're going to only publish this or that. We're not going to publish anything about vaccines. So coming forward, if it starts again, I'll be very suspicious.
And, in this, I moved, I almost should have put Ebola right next to the Marburg, right? So I talked about the fact that another case has been confirmed of Marburg, hemorrhagic virus in Tanzania. But right across the border, it is right across the border, Ebola. You ready for this? So first we read there's a potential Ebola outbreak reported in the DRC. And then, and you've got to give me, Steph Langel's email. Uganda confirms outbreak of Ebola in capital city Kampala. There's already 1 dead. Right, I just say that because Steph was just in Kampala, Uganda, the capital.
That's right.
And they show a picture in one of the articles, which I'm very familiar with. Oh my, Kampala is an incredibly populated, densely populated, crowded urban center. This is not a great place. So
wow, look at that.
Yeah, I still have Steph's Duke email address. I got to update because where is Dr. Langel now?
Case Western Reserve.
All right, moving her around. Polio, right? Enough isn't in the Washington Post. Polio outbreak spreads in Pakistan as militants target vaccination teams. And Pakistan reported at least 73 cases last year. And now we're hearing that it's spreading rapidly in some of these areas. And what are they doing? They're targeting the vaccination teams. Maybe because they're doing oral vaccination and they want the IPV vaccine. Mm-hmm. Is that what you're going with?
I don't think they know the difference.
Okay. All right. They should listen. We should send a link to the Taliban. All right. If we have any listeners in the Taliban, send a link out to your friends. All right. Mpox. As we discussed last week, the Mpox virus that causes the monkeypox virus that causes Mpox, the disease, is still spreading in Africa. And we actually, CDC announced before the blackout, enrollment started in the Africa CDC-led Mpox therapeutic study, MOSA. And as people who've been listening may have heard, that tecovirimat, right, which was really impressive in some animal studies, recent results from the POM 007 and STOMP, right? STOMP was actually, we were helping get people into the STOMP trial with Jason Zucker at Columbia, being very involved in that. It just really didn't look like tecovirimat was making much of a difference. So here they're evaluating safety efficacy of brincidofovir. And this is actually being sponsored by the African-based Panther. So the Panther is the Pandemic Preparedness Platform for Health and Emerging Infections Response. And Panther is the first African-led pandemic preparedness platform for health, emerging infection response. And we'll leave a link into their kind of blurb about who they are. But unfortunately, with where things are headed, I think Africa is going to need to have Africa-based, African-led organizations. And why do I say that? Because PEPFAR, We talked last week about a U.S. plan to exit the WHO and instead replace the capacity and activities with a U.S.-based Office of Pandemic Preparedness and Response Policy. And this week, something that had been a long time coming is the U.S. stepping back from PEPFAR. And this program was put in place by prior President George W. Bush. And there was an article, I'll leave a link into it. Trump pauses disbursements to programs supplying HIV treatment worldwide. And PEPFAR is estimated to have delivered life-saving treatment to as many as 25 million people, 554 countries. And this funding delay may last as long as 180 days. And just a little bit about this. So we're talking about medications for about 500,000 children, 500,000 children. We're talking about millions of adults. We're talking about over 200,000 people a day. And this is the President's Emergency Plan for AIDS Relief, known as PEPFAR. It's a $7.5 billion program overseen by the State Department. We did hear, it was actually a separate directive, that they're going to be reviewing their final decisions, may take up to 180 days. So they may not be sending the funds out. But just to give you some background here, this isn't just about HIV care. PEPFAR has really established infrastructure. It actually covers tuberculosis treatments. It covers a lot of other treatments. It's actually created a significant amount of infrastructure. It's credited with saving over 25 million lives. Now, we did hear that there might be a waiver to cover HIV medications. But what I hear from people on the ground is that the clinics are already limiting hours. So, hey, it's 2:30 if you're not here to pick up your medicines. But then again, they shut down the computers. So you don't know who gets what medicines. So I'm not sure how this is supposed to work. Like this waiver, it's okay, we'll still pay for the HIV medicines, but we don't know who gets what. And you don't just show up and say, I need, my HIV medicines. You actually need providers. It isn't just one HIV medication that works for everyone. Different programs have a first line, a second line. So, I have to say, in Africa, G.W. Bush is revered. I mean, he really did something tremendous, the Republican president. And I don't know why our current president doesn't want to move forward and be as well respected as GW is.
Because he's mean.
All right, Vincent. So this is what I really think we need to talk about. Okay. Avian flu or bird flu. Catchy title to the article. Egg prices are high. They will likely go higher. I have to say they already have. So we've talked about the One Health, right? One Health. Not One Health aspect, but the One Health aspect of avian influenza with its impact on milk production, right? Spreads across, get a drop in milk production. But we've also talked about the fact that it spreads to the chickens, leading to loss of millions of egg-laying chickens. So here in this article, it's an 8-minute listen. So if you don't like to read, a lot of people don't like to read, you can just click, in 8 minutes, you'll hear about this. They lay out that since 2022, the H5N1 virus has infected or led to the deaths of over 100 million birds here in the United States. And recently, this has intensified. More than 30 million hens, roughly 10% of the nation's remaining egg-laying population, have been killed in just the last 3 months. We're already below the critical number of egg-laying chickens to meet the demand. And one of the things I want to point out, it's going to take months and months to repopulate the hens. So if you get wiped out and you order some baby chicks, right now you're not going to receive your order until April or October of 2026. 2026, over a year. So right now, most of this cost is being borne by retailers. The retailers are paying $7, $8, or $9 per dozen. And so this was really interesting to me. I didn't know about this, learning about this. So what happens is grocery stores have certain price products like milk or eggs that they term loss leaders. So they actually sell them to the consumer for less than the wholesale price to entice people to get into the store. Right? So they might be paying $8, $9, $10 a dozen, but then they sell them to you for $3 just because, oh, well, then you'll get in the store and then you'll go, I don't know what you'll buy, but you'll buy some other stuff. What I will just sort of personal, I'll throw in here. My wife went to the store. I think the grocery stores, at least in our area, they're just done with this. $10.40 for a dozen eggs right here on Long Island.
Well, what about the chickens themselves that you eat? Aren't they going to go up in price too?
So a lot of this has been hitting our egg laying hens, but yeah. And it's not just the eggs. It's not just chicken. But it's also spreading to turkeys. I think I mentioned last week, actually I'll mention it here, wiped out the last duck, I guess farm is how they call that here. So there was just here on Long Island, 100,000 ducks at a Long Island. It was the last of the Long Island duck producers. They're probably going to have to close because all these folks, the ducks are dead. People are out of work. So what to do, right? So right now, I just want to point out, we are having an H5N1 crisis that is affecting what for a lot of Americans is a affordable source of protein. So what about just vaccinating the remaining 300 million hens before they all die? And unfortunately, as was discussed in this article, if you vaccinate poultry, a lot of countries will use this as an excuse to either tariff or block your export. And the U.S. actually exports about $5.5 billion in poultry meat every year. The other thing I want to point out is that the U.S., according to the Department of Agriculture, none of the current vaccines available are actually matched to the current virulent strain found in this most recent outbreak. And I have a little quote and a link there on that as well.
What's the objection to vaccinating? I don't get that.
So one of the concerns with vaccination is that, and they've used this in the past with cattle, if you vaccinate certain animals, then other countries will say, "Oh, we don't want that. There must be some kind of a problem if you're needing to vaccinate." It's sort of more of a head in the sand, seemingly approach.
Yeah, there is a problem. It's called H5N1.
You're right.
If we don't vaccinate, you're not going to get any chickens at all. This is so stupid.
Yeah,
backwards.
Well, but you know what though, Vincent? I've been listening to some stuff like with the Senate in the last couple of days here, and this whole germ theory thing that a lot of you science types embrace, it may not be true. It may be that the chickens are getting sick because of bad lifestyle choices.
Yes, right. Chickens have always had dubious choices. Yeah.
All right. So yeah, those, I don't know, because if you see the way those chickens take care of just poor character, they go out with wet hair, actually wet feathers. Okay. It gets worse, right? If the highly pathogenic H5N1 was not enough, we have highly pathogenic H5N9. And this was identified for the first time in U.S. poultry out in California. And so in Merced County, they detected H5N1 and H5N9 and H5N1 in a duck farm. And what they're actually concerned about is there may have been a reassortment, because the thing we know about the RNA influenza viruses is there are these 8 little RNA pieces and they can actually reassort. So there's a concern that maybe from the ducks, this spread into the poultry, into the chickens. So, and the ducks don't necessarily get that sick usually, but then they can fly around, they can intermingle, and they can actually spread this. So
community spread.
And then to just before we get into human, Rose Acre Farms, and our people are familiar with Rose Acre Farms, the nation's second largest egg producer. So second largest egg producer in the United States. They just had this beautiful expansion in Seymour, Indiana, so they can have 2.8 million hens. And it's this whole, what do you call it when the chickens can just wander around?
Free range.
Free range. Free range. I thought that was a type of parenting, but okay, free range chickens. You get your free range eggs, which apparently they can charge more for. Apparently there's some eggs at the grocery store that were $12 a dozen, which my wife did not spend money on, but she spent the $10.40 on those eggs, which I'm not going to eat because that's just too much money. But they just spent millions of dollars to expand their operation. They got a waiver from the local folks so that they could build these new free-range hen houses, maybe a little closer than they should have been to each other. This farm, the number I heard was 2.8 million hens may be culled, which is another huge chunk. I mean, we're already like the hens are just dropping like flies.
Well, we're not going to have eggs or chickens.
Yeah. But it's okay, right? Because the CDC is going to jump in and they're going to be on top of this and they'll spread information and we'll need to know what we need to do. And then we'll get funding and the NIH and everyone will jump in and help us with some flu vaccines. And I think now is not a good time to be pausing everything for 8 years.
You know why it's happening? Because there are not people in the White House that can think about consequences. They just say, we got to stop communication so we can control it. They have no clue about why the communications are important. Thoughtlessness. This bothers me more than anything else.
Yeah. Well, I think people need to know about this, right? And so, people need to know that we are, should I worry about H5N1? I mean, it's as we've been talking for a while here, it can have a huge impact. And it doesn't have to be people necessarily getting sick. All right. But people getting sick, that's what we're moving on to because human influenza A still at high levels. I've got data going back to January 18th, looking at our map, but I don't have anything more updated from the CDC. We'll see next week where we are, but you can see across the country we're still high in most parts of our country. There's only a few areas where it's not so high. RSV, still at a high level. And really pretty similar. We'll see if we continue to get any more updates. But we also did get some good science this week out of the Lancet Infectious Diseases, the article Respiratory Syncytial Virus Vaccine Effectiveness Among U.S. Veterans, September 2023 to March 2024, a target trial emulation study. And this they used electronic health records in the Veterans Health Administration to emulate a target trial, looking at the effectiveness of a single dose, right, of the recombinant stabilized prefusion F protein RSV vaccine versus no vaccination. And they're looking at veterans 60 and older, 146,852 vaccinated folks compared to 582,936 controls. The primary outcome was any positive RSV test from day 14 followed the matched index state. Secondary outcomes, which we care more about, by the way, were hospitalization, emergency department, or urgent care encounters. The vaccine effectiveness for a positive test was 78.1%. Secondary outcomes, vaccine effectiveness, 78.7% against ED or urgent care, and over 80% effective against RSV-associated hospitalizations. So
it's very good.
Good stuff. Good stuff. So, if you think of the 10 to 20,000 individuals, adults that die from RSV each winter, 80% reduction in these folks ending up in the hospital, really another reason why we need to communicate about the RSV vaccine. I don't know if people have done such a good job. We need to really spend money on communication. All right. COVID update, SARS-CoV-2 activity. It is high. We're not seeing much change. The data that I have here is data through January 11th, posted January 21st, and this is provisional deaths due to COVID. Most parts of the country, it's in a sort of a low area, but 2 to 4% in a number of states: New York, New Jersey, Pennsylvania, and a few others. And last updated on the 23rd of January, we'll see if we get more. It looks like we may have peaked. We may be coming off our peak for SARS-CoV-2, looking at wastewater. So a little bit of good news in this, this miasma of bad news. Not much updated here on COVID, the early viral phase. Remember, that's that first week when a patient is not hypoxic. Still same recommendations. Number 1, Paxlovid, remdesivir, molnupiravir, some context convalescent plasma, and we do have isolation guidance. Second, early inflammatory phase. That's often when people started to feel better, and then they get that cytokine storm, that inflammation, steroids in some cases, anticoagulation, pulmonary support, remdesivir, and in some cases immune modulation. And a few articles here in our COVID late phase, past long COVID section, and continue to leave links in for the article in Open Forum Infectious Disease, the Long COVID Treatment Center at Columbia, the website Long COVID, The Answers. But we have the article, The Current and Future Burden of Long COVID in the United States, recently published in JID. The article is more of an economic analysis, and it hinges on the opening claim that long COVID, which affects an estimated 44.69 to 48.04 million in the U.S., is an ongoing public health concern. So you have to sort of start with how many people are actually impacted. And then they make another assessment of what's the actual average cost. And basically saying somewhere between $5,000 to $12,000, and that's if symptoms only last a year, if they don't actually go away. And really, the majority of that, over 90%, is productivity losses. This is people can't go to work. They can't go to school. They can't do the things that they would like to do.
It seems to me an underestimate, because a hospital visit or even a bunch of consults would be already $11,000.
It is kind of amazing. You think about these folks, like they're going to see providers with a myriad of different issues, right?
Yep.
And it's sort of how do you define long COVID, post-acute sequelae of COVID, the new diagnosis of diabetes, cardiac issues, pulmonary issues, or there's really a lot of people online, selling my vitamin pack, my rehabilitation program. And then I actually think when they estimate this $2 to $6.5 billion, it's probably an underestimation. But really just trying to point out that this is, if you don't care about people, apparently there are folks out there that really, it's the numbers that move them. This is, in addition to a tragedy with a lot of human beings suffering, this is also an economic issue. Now, this next article actually came out in the spring, but I was getting lots of questions about this. So I wanted to talk about it now and discuss this topic a little bit. And some people might be familiar with this topic now just because they might follow Physics Girl and the success she's had with this therapeutic. So the article, Transcutaneous Vagus Nerve Stimulation Improves Long COVID Symptoms in a Female Cohort, a Pilot Study. So men, you're out in the cold. This was published in Frontiers in Neurology. And so they start off with a little bit of background. Transcutaneous vagal nerve stimulation, so little t VNS, has emerged as a promising non-invasive treatment for COVID-19 conditions. And so this was a pilot study where they assessed the efficacy of the transcutaneous vagal nerve stimulation in 24 female long COVID patients, about 45 years of age, but a little bit of a variation. And they followed them. In general, they were about a year and a half out from infection. They underwent a 10-day transcutaneous vagal nerve stimulation intervention at home. So they got one of these devices, and they're going to do 30 minutes twice a day. Cognition was considered the primary outcome, with anxiety, depression, sleep, fatigue, and smell as secondary outcomes. Outcomes measured at baseline, post-intervention, and 1-month follow-up. And significant improvements were observed in various cognitive functions, anxiety, depression, and sleep at post-intervention, with benefits remaining or progressing at 1-month follow-up. Improvements in fatigue, and interesting enough, were delayed, and they didn't really reach statistical significance until you got out to a month. And what did they use? So they used this device. I'll talk a little bit about these devices, something called Parasim AVNT. So this is a London, UK-based company device. And what they actually do is they place an electrode on the left tragus of the ear. Who knows what the tragus is? So the tragus is that little area, right? It's sort of in front, like in front of the ear canal, that area that sticks out. And there's actually a branch, the auricular branch of the vagus that's there. So you attach this to the tragus, and then you use these micro pulses of current. And I put in there's got a figure where they look at the prevalence, and then they actually, particularly fluid cognition. And this is your ability, basically sort of think on the fly when people are asking you to do cognitive tasks. And really, a lot of the follow-up, it was a month later that you saw these improvements. So the actual device that they used in this trial is not available in the U.S. And I always like when you actually use something that's been used in a trial. There are a number of trials here going on in the U.S. I'll leave in a couple links to the Mount Sinai trials. There's a Mayo trial, which actually is fully enrolled, so they're closed for enrollment, but they're looking at it as well. And there I'll leave a link into a number of the different transcutaneous vagal nerve stimulators that are out there. And basically what they're doing is they're through the skin, so there's no invasion here. Some of these devices sit kind of around the neck, and it's basically accessing there. Others, as mentioned, they attach to a part of the ear. So just to kind of get that out there, if people are interested, the article, Distinct Pro-Inflammatory, Pro-Angiogenic Signatures Distinguish Children with Long COVID from Controls, published in Pediatric Research. And it's really nice when you see objective things, because there really, unfortunately, there still are people who don't, quote unquote, believe in stuff. So here they performed an extensive protein analysis of blood plasma for pediatric patients younger than 19 with long COVID, compared it to a control group. Also, kids with acute COVID, the MIS-C, remember that, the post-inflammatory syndrome, healthy controls. And here they're going to use an 8-week cutoff for classifying as long COVID. And they're going to look at, after that initial infection, negative impact on daily life that they can't explain otherwise. They end up with this diagnosis. 112 children included in the study, including 34 in that long COVID group, 32 with acute, 27 with MIS-C, 19 healthy controls. And they actually found that the pediatric long COVID folks had higher levels of the pro-inflammatory and pro-angiogenic chemokines, CXCL11, CXCL1, 5, 6, 8, TNF-SF11, OSM, and STAMBP1A. I was thinking that last one would show up. No, I'm joking. I don't expect everyone to keep track of all these chemokines. But they actually then, they have this machine learning model where they can use this profile and then say, based upon levels, can you predict, looking at just the blood work, who has long COVID, who doesn't? And they're actually 93% accurate. So, all right. And we also have a couple more articles, 3 more articles, but just brief before we get to our emails. The article, Persistent Symptoms and Clinical Findings in Adults with Post-Acute Sequelae of COVID-19, Post-COVID-19 Syndrome in the Second Year After Acute Infection, a population-based nested case control study published in PLOS Medicine. Not so encouraging as in this German long COVID cohort. 2/3 of the 982 participants with post-COVID syndrome in phase 1 still had persistent PCS. after the phase 2 clinical assessment. Most of the 32% of long COVID patients who reported an improvement during follow-up did not fully recover. So, that is not usually what we're seeing here in the U.S. We're actually seeing that time is on our side. Most people with post-COVID conditions are better by a year. But no, there certainly are individuals who are not getting better. Now, are we seeing a change in who presents with long COVID? And they've got this article, SARS-CoV-2 reinfection and incidence of post-acute sequelae of COVID-19 PASC among essential workers in New York. A retrospective cohort study published in the Lancet Regional Health Americas. I don't know if you remember, everyone was fighting over getting classified as essential. Initially, you didn't want to be essential so you could stay home and get a check. And then you wanted to be essential so you can get those vaccines. And then at some point, people didn't want the vaccines. Anyway, early on, a person, they got COVID first time and they wouldn't get better. But now what we're seeing is people get infected and infected multiple times. So here they're looking at data from 2,511 essential workers, mainly first responders with confirmed PCR or antigen positive. And basically what they're seeing is we're seeing people with PASC after multiple infections. And actually, after they adjust for all these potential confounders, multiple infections actually increased your risk. So it was a relative risk of 1.41. But you know what the biggest way you can increase your risk of getting long COVID? It's by being unvaccinated when you get that first infection. And that was a relative risk 3.29. So you triple your chance of getting long COVID by, not being vaccinated. All right, I was going to say by being anti-vax, but there are anti-vax folks out there who vaccinate themselves and their kids. They just don't want anyone else to get vaccinated. Just putting that out there. All right, the article, we'll talk about who that might be that we're referring to. So the article, Impact of COVID-19 Pandemic on the Incidence and Prevalence of Postural Orthostatic Tachycardia Syndrome, published in EJH QCCO, it's sort of a long journal name, but a rather robust study, right? So this is, do people end up getting POTS after COVID, right? And there's a POTS specialist that I recently was interacting with, and they've fortunately seen the light now. But apparently, the patient, when they first went to them, said, "I don't really know about COVID and POTS. I'm not really seeing that." Well, in this rather robust study of over 65 million patients, 64 healthcare organizations, they looked at incidence rates, incidence cases, prevalence rates. And they actually reported a significant increase. Actually, the IR increased more than 14-fold. So yes, another study, I like to say, suggesting a potential association between COVID-19 and the development of post-viral POTS. All right, so I will close us out. I think a lot of our listeners, we'll probably find out the outcome of the RFK Jr. hearing by the time this airs. But it just seems more appropriate now than ever that no one is safe until everyone is safe. I want everyone to pause the recording right here. It is, when we're recording, it's the 30th of January, but I'll announce right for you, Vincent, and all our listeners, we reached our goal for Microbe TV. So Microbe TV will be getting a check. And we are now, when this drops, we'll be starting our Floating Doctors fundraiser, where for February, March, and April, March, I'm going to be down in Panama with Floating Doctors, and we're going to double your donations. We're hoping to get to a potential maximum donation of $20,000.
Thank you, Daniel, for your contributions.
What is it that you say? You must have something about the inner scientists at TWiV and all our donors.
Yeah, I say, what is it? Something about rescue your inner scientist. Get in touch with your inner scientist. So thank you, everybody who donated. We really appreciate it. We need this going forward to help explain the science to you. Time for your questions for Daniel. You can send yours to daniel@microbe.tv. Kathy writes, I recently had my 4th bout of COVID-19 illness. All 4 were treated within 3 days of Paxlovid. As I was feeling better after my first and my most recent, I became symptomatic again and tested strongly positive using the rapid antigen test. My most recent rebound illness symptoms were at least as serious as the initial phase. I was wondering what the current guidelines are for isolation and or masking during the days after becoming sick with rebound COVID. Articles from Harvard, Johns Hopkins, CDC, and Yale all said I could be contagious and recommended 5 days of isolation. Some of these were from 2023, so perhaps not in line with current thinking. I haven't heard you speak lately about rebound COVID and wondered if you could address it again during your clinical update. TWiV continues to be a sturdy and steady ship of shared knowledge as we struggle through the stormy waters of misinformation and anti-science rhetoric. My husband and I are supporters of the show. I've listened to every episode of TWiV and Immune since first learning of Microbe TV in 2021. We're both retired scientists, biological sciences for me, chemical engineering for him, and we're grateful for the information shared, for the scientific scrutiny and objectivity you maintain while showing your caring and friendly natures. Thank you so much for your work in science and in communicating important science. We've learned so much.
Well, thank you, Kathy. That was a lovely email. What do we know? So there are these two phases of the infection, of the clinical experience of COVID-19, right? And so that first week is when we're getting a lot of viral replication. If you do a swab in the nose, you're talking about millions of nucleic acid amplification units. Now that goes down. And there is a period where people start to feel better, right, at the end of that first week. But historically, pre-Paxlovid, pre any therapeutics, we see about 20% of folks would have a second week where they feel crummy. And actually, that second week, that is where people would end up in the hospital. That's when you would end up in a cytokine storm that would end up, in some cases early on, with the case fatality rate that we were seeing during the early days of COVID. Getting Paxlovid as early as possible has the most significant impact upon the likelihood that during that second week you're going to have hypoxemia, that you're going to end up in the hospital, that you're going to end up not surviving. So, we look at it really that way, is soon as possible. Now, there are certain percent of people that, and you described this perfectly, you could have symptoms during that second week. We already talked about that. But then everyone started having these antigen tests, and they started doing that. Now, during that second week with all that inflammation, you are actually going to get a shedding of cells from the nose. You're going to pick up that protein. Now, if you did something quantitative like the PCR, you might get in the tens of thousands, but you're not going to get up into the millions. The other, which I think, and this is a little bit of a disconnect, is that we have not seen transmission during that second week. The transmission is really the first 5 to 7 days. And that's about 85-90% of the transmission. So I don't, despite the CDC suggesting this re-isolation, I don't think that's consistent with the science.
Patsy writes, thanks to you and Dr. R for your work and clear communications on healthcare. I'm a retired primary care pediatric nurse practitioner born in 1952. I did have childhood measles and mumps, but never rubella. I was vaccinated once for rubella, and 32 years ago, while pregnant, had the usual rubella titer that still showed protection. My girlhood friend in California tells me she had titers done recently, and measles titer was low, so she had 2 MMR vaccines subsequently. Despite not working in healthcare now, I am in public often and spending time with children. With measles resurgence and some outbreaks in my area of New Jersey, Philadelphia, do you recommend getting MMR titer and vaccine if below protective level? There are many boomers in this situation, but I've not seen a recommendation for screening unless born before 57 and working in healthcare.
Yeah, so Patsy, that actually, you're sort of sitting with the current recommendations. Is there are certain situations where you're going to work in healthcare, interesting enough, where we actually will do titers, and some people will get repeat vaccinations, as you describe. We really haven't seen significant issues, as far as the boomers waning. But yeah, if we find out more, if there are updated recommendations, if anyone's allowed to communicate those updated recommendations, we'll let you know.
Jessica writes, I read that benzalkonium chloride can inactivate neurovirus. Would switching from alcohol-based sanitizer to benzalkonium chloride be an effective way to prevent the spread? I understand frequent hand washing is preferable, but there are many situations when hand washing is impractical, like riding in a car, and it would be useful to have a portable alternative.
All right. So Jessica, this substance actually, sometimes it's used to like clean a wound, or sometimes it's used to clean surfaces. It can be pretty hard on the skin. So I really think soap and water, it is, hopefully you're not getting exposed to a lot of norovirus while you're in a situation like driving around in a car. Yeah, I'm not sure this would be the best portable alternative.
Amanda writes, as I sit here in the hospital with a very sick year-old, I'm curious as to why we don't vaccinate 1-year-olds for RSV unless they have other risk factors. I got the vaccine while pregnant with him, and he was born in late December. Still, so he's quite young during this first full respiratory season. If being vaccinated while pregnant only give 6 months of protection, then babies born middle to late season will still be at risk for hospitalization during our second RSV season, especially for those who practice good social distancing during the first season. Yet it's only recommended up to 8 months unless other risk factors are present. The $200 vaccine versus a many $1,000 hospital visit seems economically advantageous, even minus pain and suffering. In hindsight, I'm frustrated I didn't push for him to have this myself, as it seems a fairly obvious choice, but I'm not sure why that isn't just a recommendation, given we are vaccinating the over 65 and 1-year-olds are at similar risk, if my understanding is correct.
Yeah, this is interesting. So I brought up, this Beyfortus prescribing information, and what do they say about doing, and so the whole idea is, you have these two different doses, the 50 or the 100 milligrams, and it's actually recommended, right? So if you're born and it's going to be your first season, but then they also say this sort of interesting wording: children up to 24 months of age who remain vulnerable to severe RSV disease through their second RSV season. Which seems to me pretty broad. Yeah, and I agree with you. This is a very safe, very effective, and this is that passive vaccination, the nirsevimab, the Beyfortus. Yeah.
And Jim writes, I start every Saturday morning with the clinical update. It's good to know that someone is following all of this information and making it available to the public. Been very interested in your recent discussions of IPV and OPV. My question is, are those of us who took OPV many years ago protected from poliomyelitis? Should we be looking to get IPV?
Vincent, you can field this.
No boost of IPV is needed. The immunity you got from administration of OPV is equally efficient as that following IPV in the prevention of paralytic poliomyelitis. You're good to go, Jim. Agree with that, Daniel?
I agree.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, particularly in these times, be safe.